called Anthem. It's actually more technically called WellPoint. And the CEO, Larry Glasscock, lives in Indianapolis. He's the highest paid executive in Indiana. His bonus in 2003, $42.5 million. Now, before you get too shocked, I want to tell you, last year was a bad year for him. He only made $26 million last year. Okay? Now, you may have read some of the stuff in the papers in the last couple of days, because even though he's the boss of the biggest health insurance company in the world, he's not the highest paid executive in healthcare. That's this guy, McGuire, who resigned 1 or 2 days ago after he received $1.8 billion, $1.8 billion in stock options over the last few years for United Healthcare. And he just stepped down because of the scandal about the way, not that they gave him that many stock options, but the way they gave him the stock options was what's called backdating. So there's a lot of money in our system. There's a ton of money in our system, as a matter of fact. So let's think a little bit and look a little bit, where does all this money come from and where does all the money go? Because there are some people who are getting pretty rich on our healthcare system. So here's another one of these slides that kind of starts slow and goes forever. So this is per capita national health spending. And here we see it rising to over $4,000 per person per year in the year 2000. And this slide, at the bottom here, we see the U.S., and this is now up to 2004 data, spending $5,000 per person per year. So that's how much money we're spending as a nation. So we're going to look for a second at the other countries who might be interesting to compare ourselves to and see if we can learn a thing or two from these other countries. So Japan, the United Kingdom, Sweden, France, Germany, Canada, all these countries spend about half of what we do. Remember, this is set at per capita, per person per year, so it doesn't matter how big the country is. This is all adjusted for that. So these countries spend half of what we do. I mean, that's amazing. They spend so much less than we do. Now, the red part of the line is how much we spend per capita in tax dollars, and the green part of the line is how much we spend per capita in out-of-pocket expenses. Actually, right now, we're spending over $7,000 per person per year. $2 trillion we're going to spend this year on healthcare. It's a lot of money. So where does the money go? An awful lot of our money doesn't go to healthcare. It goes to overhead, inefficiency, waste, profit, and fraud. We'll talk about those. Now, this is a slide I love to show to my friends who are hospital administrators. You see the little blue line, that's the growth in the physician supply, and then the green line, the growth in the number of nurses, and then the gold is the growth in the number of administrators. There are an awful lot of administrators. So I like to give my administrator friends a hard time about that when you see how administrators have grown over the last 30 years. So what do? Most of you may have never actually read a hospital bill. But if you get sick and get hospitalized and go to the hospital and then you get home and then eventually you get a bill, and it usually goes pages and pages, and you go, and if you read through that bill and you look at, and somewhere along the line you're going to have this moment where you say, oh my God, they charged me $5 for an aspirin tablet, or they charged me $50 to put an ACE bandage on me. I mean, it's just unbelievable. The way the bills are put together, there are armies of people who make the bills, there are armies of people then at the insurance company who fight the bills. There's a lot of overhead and a lot of inefficiency just in the billing of it, and that's where a lot of the inefficiency comes in. I'll pick on my own profession in the ER. In the ER, you go to the ER and get a couple X-rays and a cast on your arm, it'll be $500 before you know it. How can we charge so much in the ER for that? Well, another way our system is so inefficient is what's called cost shifting, is that we charge a lot for the people who can pay because remember, we're the safety net, we're taking care of all these people who can't pay. So, if 20% of the people who come through our door aren't going to be able to pay anything on their bill, then we've got to shift the costs around. And it's a very inefficient way to run a system, and it ends up being very expensive for those who do pay their bills. So there is a way that you can make money in medicine, particularly if you avoid taking care of people who are really sick, if you avoid taking care of people who aren't going to pay their bills, if you avoid people on Medicaid, which doesn't pay very well. So if you avoid them, you can skim the cream off the top, and that's one way you can make a lot of money in medicine. But it's like, it's like gaming the system. It's like a game of Survivor. And it's so crazy and inefficient, and that's why it takes a lot of people administratively to kind of run our system, because we're doing all this gaming the system back and forth. So we're paying for this incredibly complicated system. There are over 7,000 different insurance plans. Not 7,000 different companies, but every company offers 1 million different plans. There's an army of people trying to deny health insurance coverage and payments, working at the insurance companies then, and an army of people trying to maximize and receive their payments, working at the doctor's offices and at the hospitals, and an army of people who trying to determine who's eligible for what program and who's got a pre-existing condition and all this stuff. I mean, just all this stuff that has nothing to do with health care. So, if you look at the overhead spending, and Medicare's blank right here in our first look at this slide. The old not-for-profit Blue Crosses, there are a few of them left, and they run about 16% overhead. And then you go out to the commercial carriers like Aetna, there's a bunch of them, and then you go to the investor-owned Blues, like our Anthem WellPoint. They run 26% overhead. That's part of where those salaries are coming from. But they're incredibly inefficient. All that, only 74% or 73.5% of the money that they take in actually ends up going for health care. So where's Medicare come in? Well, Medicare runs about 3.1% overhead. So the big bad government bureaucracy doesn't sound so bad after all, because Medicare, it turns out, is really a lean, mean billing machine, particularly when you compare it with these private insurance companies. So what would happen if we in the United States ran our system with Medicare-like efficiency, and we can actually use data from Canada for an example, because the Canadian system runs a lot like our Medicare system. And in Canada, it turns out they spend per person per year, this is all stuff published in the New England Journal of Medicine, they spend about $407 per person per year, and we spend, just on insurance, just on overhead and administration, we spend almost $1,400, almost $1,000 more per person per year we spend just on the administrative side of things. So we could save $286 billion was the number that they published in 2003. And they determined this is enough, we could save enough if we could run our system as efficiently as Medicare to cover all the uninsured. We could cover everybody and then some. So there's a myth that we can't afford to take care of everybody. And the truth is, there's plenty of money in the system already, and here's one place we could cut and move a whole bunch of money. And I'll also point out that these are not just numbers that from the New England Journal of Medicine 2003. These numbers have been done other times by the CBO, which is the Congressional Budget Office, and the General Accounting Office, the GAO. The numbers have been done a number of times. If we ran the system more efficiently, we'd have a ton of money left over. This guy says to his kids, your mother and I spent so much money on health insurance this year that instead of vacation, we're all going in for elective surgery. And I said fraud, too. So this is a quote from the Journal of the American Medical Association, an article published in 2003. Investor ownership has been shown to compromise quality of care in hospitals, nursing homes, dialysis facilities, and HMOs. For-profit hospitals are particularly costly. A wide array of investor-owned firms have defrauded Medicare and been implicated in other illegal activities. Now this article's got about 200 references about fraud, but we're just going to talk about one case, Columbia HCA. Columbia HCA is headquartered in Nashville, Tennessee, and it is the largest for-profit hospital chain in the country. They were fined $1.7 billion with a B dollars for Medicare fraud. I mean, this is an incredible amount of money. The largest fine in Medicare history. Nobody went to jail, and the CEO left with a huge golden parachute. So that's the kind of what we're talking about. This is the worst example of fraud, but it's a problem, and we need to deal with it. We'll come back to Columbia HCA a little later.